Welcome to this comprehensive educational session on clinical writing. Today we will explore common vocabularies used to describe symptoms and clinical presentations, specifically focusing on items 16 through 30 in our medical curriculum. Number 16, shortness of breath. This is one of the most common reasons patients seek medical attention, often described as an uncomfortable awareness of breathing. In a clinical context, it's vital to capture the patient's exact experience. In clinical notes, it is essential to document the onset, duration, and any factors that exacerbate or relieve this sensation. Is it sudden or gradual? Does it happen at rest or with activity? These details are crucial for diagnosis. An example of its use in writing is, the patient reports acute shortness of breath after walking short distances. This phrasing clearly indicates both the timing and the trigger of the symptom. Number 17, exertional dyspnea. This term specifically refers to shortness of breath that occurs during physical activity. It is a more formal and precise way to describe getting winded during exercise. It is a key indicator of cardiac or pulmonary function and is often graded to assess the severity of the patient's condition. Clinicians often use standardized scales like the NYHA classification to categorize its impact. In a professional report, you might write, "The patient experiences exertional dyspnea when climbing a single flight of stairs." This provides a clear, measurable baseline for the patient's current functional status. Number 18, productive cough. This describes a cough that results in the expectoration of phlegm or mucus. Differentiating this from a dry, non-productive cough is essential for narrowing down a diagnosis. When documenting a productive cough, clinical professionals note the color, consistency, and volume of the sputum produced. These descriptors can suggest an infectious versus a non-infectious cause. For instance, the patient presents with a persistent productive cough accompanied by yellowish sputum for 3 days. This description provides a clear timeline and physical evidence for the clinician. Number 19, reduced mobility. This refers to a decrease in the patient's ability to move around freely and independently. It can range from a slight limp to a total inability to ambulate. It can stem from various causes, including pain, muscle weakness, or neurological impairments. Documenting whether it's a new change or a chronic condition is a vital part of the medical history. You might record, "The patient has significant reduced mobility following a recent fall and requires assistance for all transfers." This note highlights both the cause and the resulting care need. Number 20, generalized weakness. This is a non-specific feeling of being physically weak all over the body, rather than in one specific limb or muscle group. Unlike localized weakness, generalized weakness often indicates a systemic issue, such as an infection, anemia, or a metabolic imbalance. It is important to ask the patient how long this has been occurring. Example, the patient reported generalized weakness and malaise that has worsened over the past week. Using malaise alongside weakness adds another layer of clinical accuracy to your writing. Number 21, loss of appetite, also known clinically as anorexia. In this context, it refers to the symptom of a decreased desire to eat, which can be caused by many different medical conditions. Persistent loss of appetite can lead to unintended weight loss and nutritional deficiencies. Clinicians must assess how much the intake has changed and if there are associated symptoms like nausea or pain. In writing, the patient mentions a sudden loss of appetite, contributing to a 5-pound weight loss this month. This clearly connects the symptom to a measurable clinical outcome like weight loss. Number 22, fatigue. This is a subjective feeling of tiredness or lack of energy that is not relieved by sleep. It is one of the most frequently reported symptoms across all medical specialties. It is important to differentiate between physical fatigue and mental exhaustion in clinical assessments. We also look at how fatigue interferes with daily tasks, which helps us understand its severity. For example, the patient describes chronic fatigue that significantly impacts their activities of daily living. This sentence shows that the symptom is persistent and functionally significant. Number 23, dizziness. This is a broad and subjective term used by patients to describe sensations like lightheadedness, unsteadiness, or vertigo, which is the sensation of the room spinning. Clinicians must determine if the dizziness is related to balance, blood pressure changes, or other neurological factors. Asking about triggers like standing up quickly helps clarify the cause. You might write, "The patient experiences intermittent episodes of dizziness, particularly when transitioning to a standing position." This suggests a potential orthostatic component to their symptoms. Number 24. Chest discomfort. This is a cautious and professional term used to describe pain, pressure, or tightness in the chest area, avoiding premature assumptions about the cause. It is vital to clarify the nature of the discomfort. Is it sharp, dull, or does it feel like a heavy pressure? Does it worsen with breathing or movement? These descriptors help differentiate cardiac from non-cardiac causes. Example: the patient presents with substernal chest discomfort that radiates to the left arm. This classic description uses precise anatomical terms to communicate the patient's experience. Number 25. Nausea. This is the subjective sensation of an urge to vomit. It is often accompanied by abdominal discomfort and can be a side effect of medication or a symptom of illness. Documentation should include the frequency, timing, and any associated symptoms like emesis, which is actual vomiting, or diaphoresis, which is excessive sweating. This context is key for clinical evaluation. In a report, mild nausea was reported by the patient shortly after the administration of the new medication. This clearly links the symptom to a specific event in the patient's care. Number 26. Impaired sleep. This is a general term that covers various disturbances, including difficulty falling asleep, staying asleep, or experiencing non-restorative sleep. Quality of sleep is a major factor in overall health and recovery. Its impairment should be carefully noted, along with any suspected causes like pain, anxiety, or environmental factors. Example: the patient reports impaired sleep over the last fortnight due to a persistent nocturnal cough. Using the word nocturnal specifies that the symptom is occurring specifically at night. Number 27. Urinary frequency. This refers to the need to urinate more often than usual, which can be a sign of infection, diabetes, or other underlying issues. It is important to distinguish between frequency, needing to go often, and polyuria, which is passing abnormally large volumes of urine. We also look for nocturia, which is needing to urinate during the night. You might write, "The patient has noted increased urinary frequency, particularly during the nighttime hours, which we document as nocturia." This precision is essential for professional notes. Number 28. Cognitive decline. This refers to a noticeable decrease in mental functions such as memory, thinking, and reasoning that goes beyond what is expected for normal aging. Clinicians use standardized tests like the MMSE to assess the degree of decline and its impact on the patient's independence and ability to safely perform daily activities. For instance, family members have observed a gradual cognitive decline and increasing forgetfulness in the patient over the past year. This provides a clear time frame and source for the observation. Number 29. Reduced exercise tolerance. This is a decrease in the ability to perform physical tasks or exercise that were previously easy for the patient. It is often an early sign of deteriorating cardiac or respiratory health and warrants further investigation into the patient's aerobic capacity and any associated symptoms like chest pain or breathlessness. Example: the patient reports a significant reduced exercise tolerance over the last 6 months, noticing they tire much faster during their daily walk. This adds concrete detail to the clinical report. Number 30. Functional limitation. This refers to any restriction in performing basic activities of daily living, often as a result of a physical or cognitive impairment. Assessing functional limitations helps in planning rehabilitation and social support. We look at specific tasks like dressing, cooking, and mobility to determine the level of care needed. In writing, the patient exhibits functional limitation, requiring assistance with simple household chores. This note clearly communicates the impact of the patient's condition on their life. This concludes our detailed review of clinical vocabularies 16 through 30. Mastery of these terms is essential for clear and professional medical documentation. We hope this session helps you in your clinical practice. Thank you for watching.